έτσι. Να φωνάξω στο πόντιουμ την Penelope de Politis. Αν και μιλάει εξαιρετικά ελληνικά, θα προτιμήσει έτσι να κάνει την ομιλία της στα αγγλικά, γιατί νιώθει πιο άνετα και εμείς θα την ευχαριστήσουμε για αυτό.
Ευχαριστώ. Λοιπόν, ναι, καταρχάς θέλω να σας ζητήσω συγγνώμη, θα σας μιλήσω στα αγγλικά, γιατί στα ελληνικά έχω μόλις 2 χρόνια και το 1/4 θα γίνει μισή ώρα. Αλλά πρώτα θέλω να πω στα ελληνικά ένα μεγάλο ευχαριστώ στο Ophthalmica, ειδικά στο Mute που μου άνοιξε την πόρτα και thank you very much for making me feel at home. Είναι μεγάλη μου τιμή και χαρά να είμαι καθημερινά ανάμεσα σε τόσο κορυφαίους συνάδελφους και αφού είναι η πρώτη φορά που αντιπροσωπεύω το Ινστιτούτο σε συνειδριακό περιβάλλον, θέλω να σας πω μέσα από την καρδιά μου. Λοιπόν, ξεκινάμε. Να το κάνω. Ολόκληρη οθόνη είναι? Ναι. Μπορώ να το κάνω ολόκληρη οθόνη. Λοιπόν. First, I'm just going to brush up a little on theory, and then we're going to skip straight to the clinical cases. First, let's consider what's a corneal ulcer. Is it an emergency or an urgency situation? It's certainly not routine, right? By definition, an emergency or an urgency in medicine is a situation that poses a risk either to life or to a vital function like vision. The difference is that the emergency must be solved immediately, while the urgency can have its initial management within the first 24 to 48 hours. Still, corneal ulcer is a vision-threatening condition, and therefore it must be handled as soon as possible, in order to avoid potential complications such as loss of transparency of the cornea and progression to more severe situations like endophthalmitis, perforation, and even loss of the eye. Let's remember that the cornea is a vessel-deprived tissue. This is a major advantage when it comes to corneal transplant, but it's a bit of a problem when we want it to heal or to fight infection effectively. Differently from superficial keratitis, where the lesion is limited to the epithelium, corneal ulcers, the problem goes into the stroma. And while the epithelium heals fast, leaving no scar, the stroma lacks these features. This is a lovely illustration of the corneal layers by my friend and colleague, Renato Ambrosio Jr., with whom I worked for many years in Brazil. You all know him from the Bell and Ambrosio display in the Pentagon. It features, this illustration features in the book that goes along with the campaign, his international campaign for keratoconus awareness that started in 2018. And me and my fellows at Ophthalmica had the mission to translate the book. And it's already going to the 2nd edition, the first vanished. And we are bringing the campaign to Greece for the first time this year. You are to expect a nice event towards November. You can download the book for free from the Ophthalmica website. So let's go into corneal ulcers. A patient with a corneal ulcer will usually present with a red eye, painfully red eye, and will have some sort of risk factor. A corneal ulcer doesn't just simply show up out of the blue. There must be something that causes it. And fighting the risk factor is very important so we can prevent an acute ulcer from becoming a chronic or a recurrent ulcer. Other symptoms that might be present are foreign body sensation, photophobia, redness, tearing, decreased visual acuity to various degrees of severity. Talking about risk factors, the most common risk factors are contact lens wear, especially when it comes to soft contact lenses, extended wear for many, many hours a day, and poor care with the lenses, with disinfection. Corneal trauma, including surgery, especially corneal. And talking about refractive surgery, I think that sometime soon we will stop removing epithelium for good in PRK because there's no reason really, and it just increases infection rate. Contaminated eye drops, those that are forgotten in the cabinet, this is a very common risk factor for corneal ulcer. So we must, it's very important that we guide our patients to discharge, to get new drops whenever they're going to use it. Tear film deficiency, anything that affects the equilibrium and the balance of the corneal of the ocular surface can lead to an entrance to bacteria and to impair the corneal epithelium and progress to corneal ulcer. So the abnormal position of the eyelids and lashes is another risk factor, blepharitis, corneal anesthesia and exposure, also by bad positioning of the eyelids and lashes, and lesions to the 5th or 7th corneal nerves, in autoimmune and cicatricial diseases as Stevens-Johnson and cicatricial pemphigoid. So what do we do when you're facing a situation like this? This photo is a courtesy of my master in corneal ulcer, Patricia Contarini. I hope sometime soon we can bring her to Greece to speak in my place. And she's one of the best in Brazil, certainly the best in Rio. And we see here, this is a very severe corneal ulcer. We have here infiltrate. We have an abscess, a limbal abscess. This was inflammatory, the abscess. She collected the sample, and it was sterile. So she did corticoid over here. When we're dealing with corneal ulcers, the management stands basically on two axes. We have to consider duration of the ulcer. Is it first time? Is it an acute ulcer? Or is it chronic, recurrent? So we're gonna need a more prolonged follow-up. About the cause, is it infectious? Is it non-infectious, sterile ulcer? This is gonna guide the way we're gonna deal with it. So when it comes to infectious ulcers, they're gonna fall mostly into four categories. Let's leave outside the atypical microorganisms. Bacterial, fungal, viral, or protozoal. But let's keep in mind the possibility of superinfection. There's nothing preventing corneal ulcer from having more than one class of microorganisms. While non-infectious ulcers can be either traumatic, and that includes trichiasis and shield ulcer from vernal conjunctivitis, that is basically anything that rubs against the cornea, can damage it and predispose it to corneal ulcer. Exposure-related ulcers, including those caused by imbalance of the ocular surface. Neurotrophic, when the epithelium fails to heal properly, including posthepatic, those are the most common causes. And peripheral, including those marginal ulcers caused by staphylococcal toxins. Let's remember that a non-infectious ulcer can always become secondarily infected. and therefore a disrupted epithelium needs antimicrobial coverage. Treatment will follow two goals. First, fighting the cause, either biological or mechanical, and relieving symptoms, usually by using those classes of medications to fight photophobia and giving more comfort to the patient. Of course, good lubrication in order to promote fast healing. So the steps we will follow one by one are, first, make an initial diagnosis based on history and clinical findings. Collect samples when you suspect infection. And remember, everything can be cultured. We are dealing with very small samples, very, very minute, and it's more than frequent that cultures will come out negative. It's a good idea to work together with a lab familiar with ocular samples and with the paucity of the material that we provide them. And we cannot be sure that we will find our causing microorganism into that sample. So we send contact lenses, the contact lens case, everything that has touched that eye can be the source of our etiological agent. Start empirical antimicrobial therapy. Do not leave your patient uncovered. You can use either a broad spectrum drug or a combined regimen and just adjust it once you get the results from the lab, or if you have no response in 48 hours. Remember, cultures may take many days to give a result, but gram staining is done in a few minutes. So if you have a good partnership with your lab, they will give it something. They will give something to you rather quickly. Of course, stop potential hazards. Let's not talk contact lenses. That's obvious. But corticoids, when you're dealing with a suspicion of fungus or virus, the class of drug must be away, at least in the beginning. And follow up your patient closely, even daily. Let's not forget law implications. We're dealing with not routine. It's an urgency situation. Debride if necessary, especially when there is necrosis or if it's a fungal infection. There's no use using the right drug combination, and when the drug has no access to the actual site of action. So sometimes in the case of fungal infection, you may need daily debridement. Correct associated disorders, whether it's a lid or a systemic problem that is predisposing that eye to have a corneal ulcer. Minimize damage, always. Do not use 50 drugs. They all have preservatives. Give preference always, when possible, to unpreserved solutions, and act promptly in order to stop the mechanism, the pathogenic mechanism that's destroying that tissue. Watch for imminent perforation. Indicate, by all means, a hot graft if necessary. Don't fear losing the cornea, fear losing the eye. So let's start with our cases. First one is a woman, 48 years old. She's a contact lens wearer, and she came to us using tobramycin. By the way, all these photographs that you will see here are from the Ophthalmica Institute. And she came using tobramycin on her own, given by a pharmacist. And we can see here an ulcer that takes up virtually 1/4 of, virtually a quadrant of the cornea. There's also impopion down here. And some conjunctival injection. So we suspend the drops for 48 hours in order to collect culture. We start empirical therapy using the clinical protocol. Vancomycin, ceftazidime, moxifloxacin, drops hourly, and vibromycin per month every 12 hours. And the culture came up with Enterococcus faecalis. We kept vancomycin hourly, moxifloxacin just in case if there is a superinfection that the culture didn't get. And the patient has a good resolution in 2 weeks. Case 2 is a man, 67 years old. He does some Burle work, and he's using ofloxacin for 10 days now. With no improvement whatsoever. As we can see here, he has massive, it's kind of dark. There's massive conjunctival injection, there's chemosis, there's epopium over here, and kind of a blurry, not well-defined infiltrate in the cornea. So that makes us think of fungus. So we collect a sample for culture. We start amphotericin B and voriconazole, and both topic and oral. And the culture did come up with Candida albicans. We kept the regimen, and in 1 week, it started to improve. Let's remember that fungus are slow growing, slow everything, microorganisms, so it takes some patience here. So since we are almost sure that's fungus, we wait for the culture, we wait and for improvement as well. Case 3 is a man 38 years old. He was referred to us with a suspicion of acanthamoeba, but he has no history of contact lens, no pain. Acanthamoeba usually gives excruciating pain, unproportionate to clinical findings, so it's virtually impossible to be acanthamoeba. And we see those signs, a ring infiltrate over here. There's no perineuritis, and there's very mild conjunctival injection. So we do confocal microscopy. We suspect stromal hypersimplex. We start dexamethasone drops and cover the patient with valociclovir, and he has a favorable outcome. Case 4 is a female, 52 years old, chronic contact lens wearer, high hyperopia, and she wears her lens every single day for 14 hours a day. She changes her lens every 3 months instead of monthly. And her solution, cleaning solution, she doesn't remember. How do you use something every day and you don't remember it? So that tells us that's kind of careless, the way she manages and she handles her contact lenses. And that leads our thinking towards the most possible risk factor. She has pain, redness, and she's using dexamethasone drops for relief, and then she goes to a doctor when there's no relief. She's referred to us by that doctor. She was using moxifloxacin, no culture was collected, and she was already in the second week of the course of the disease. Her visual acuity was down to finger count, and there was a thick, full thickness gray-white infiltrate over here. So we culture her. I had ceftazidime for further coverage, and at 3 weeks she's like this. The culture comes out negative. Of course, she was using antibiotics first. And as I said, even if she's not using, it's not infrequent for the culture not to give any results. So we add vancomycin and amphotericin B to the regimen, and at 4 weeks, the lesion looks like this. We can even see some satellite infiltrate here above. And we switch the regimen to azithromycin. As we don't have any improvement with everything else that we were using. And at 7 weeks, the lesion looks like this. Okay, that's some response. But at 11 weeks, the pain is worse. So we collect a no culture. And another 11 weeks later, we have a PCR for acanthamoeba. We suspend everything, and we start with the proper regimen. Case 5, he's a male, 66 years old, and she had a history of epizoster a year before. He had pain, redness, and blurred vision. And as we can see here, he has a rather clean paracentral ulcer, and his sensitivity was virtually none. And he has gross blepharitis. So also here, the other findings guide our thoughts to the etiological agent of this case. First of all, this is neurotrophic, right? So first of all, we start with a complete therapy for blepharitis. And preservative-free tears whenever possible. We save therapeutic contact lenses only for when the pain is more intense. And we keep that patient close and stable now. This is a female, 52 years old, with chronic blepharitis. All she uses is artificial tears, but has no regular lid care. And we can see here there's a marginal ulcer with a sterile aspect and some conjunctival injection. We start dexamethasone drops, we taper it, give her optimal lid care, and she's fine. This is one before the last case. I'm almost done here. This is a male, 70 years old, with having undergone multiple procedures, and he shows band keratopathy with central sparing, with mild corneal edema. He undergoes PTK and EDTA chelation, and this is the postoperative aspect. And the last one, a male, 32 years old, with a trombimetal. He had undergone LASIK 13 years before. He has low visual acuity and gross astigmatism, stria irregularity. We start oxafloxacin drops and autologous serum every 4 hours, then more viscous lubricant, and mild corticoid. And 10 months later, he still has the same low vision because the lesion left a scarring, but the astigmatism is down to 1/3 of what it was before. So the take-home message is, if you don't want to end up with a crater like this, watch up your patient, for your patient, follow it close, follow him, her up close, and do whatever you have to do as early as possible. I just want to show you my grandmother, the very reason why I'm here, and she's my role model in medical practice and one of the persons that started physical therapy in Brazil, but that's another story. Thank you very much, and stay tuned for November as we're coming up with some good stuff for keratoconus. Thank you for your attention.